During a fluoroscopic examination, the operator controls activation of the X-ray tube for real-time imaging of the patient. So, an X-ray beam is passed through the body. The image is transmitted to a monitor so the movement of a body part or of an instrument or contrast agent through the body can be seen detail. Let's talk a bit more about X-ray here. So basically X-ray is an electromagnetic radiation that can be used to take images of the human. Radiologists using barium to check the functions of the stomach, the small and the large intestines, colon, and rectum. A speech-language pathologist can use fluoroscopy to see if food is going to the right place when swallowed. They can also check to see if parts of the patient's mouth and throat are working properly. In cardiac procedures, dye can be injected into the coronary arteries to show blood flow or to investigate potential blockages. Catheters may be placed more easily due to fluoroscopic guidance. Several spine and joint injections can accurately be made using fluoroscopy after dye is injected. These injections can be both diagnosis, to see if there is a greater underlying pathology, or therapeutic, sometimes providing full relief for an extended period of time. Nowadays, it is most useful in guidance for small, very mobile lesions. In this instance, the real-time fluoroscopy may be the only method of accurately placing the needle tip within a small lesion. It also offers efficient sampling options for cortical bony lesions. There were many limitations to the system, the main one being the brightness of the image. It was so dim that fluoroscopy had to be carried out in a dark room so that the radiologist's vision would be sufficiently adapted to be able to see an acceptable level of contrast in the image. Radiation-related risks associated with fluoroscopy include radiation-induced injuries to the skin and underlying tissues, burns, which occur shortly after the exposure, and radiation-induced cancers, which may occur sometime later in life. An understanding of changes in swallow associated with aging is critical to clinicians working with elderly dysphagic patients. The intent of this paper is to review current information regarding typical changes in aging with implications for swallowing. Particular emphasis is on evidence from fluoroscopic studies of swallow function. Objective measures of timing and displacement, and other observations, were collected for 63 normal, non-dysphagic adults under the age of 65 years, and 74 carefully screened, non-dysphagic volunteers over the age of 65 years. Differences between the groups are discussed, with special attention to their clinical relevance and application. Information provided will hopefully serve clinicians in recognizing typical and atypical swallow in the elderly.